What is an infection? Infection is in a state of injury or any
students.
damage that results from the process by which organisms capable of
Here is
causing
an
disease
advisory
gain
about
entry into the
COVID-19.
body and establish colonies. The oral lesion occurs by the same root, and they may originate from the local infections
to our topic today,
that is acute the oral manifestation of a local infection somewhere or a consequence of an underlying systemic disease in the individual. So in the oral mucosal environment, it contains of diverse group of microorganisms which is present with complete harmony with the host. And there are certain local systemic or environmental or idiopathic other factors that may or may not disturb this harmony. When this harmony or balance homeostasis is disturbed, it results in a pathology. So what are these factors that can alter this balance? The factors may be changes in epithelial integrity, the changes in lubrication of the mucosa, the changes in secretions of the saliva. This balance might also be altered by changes in the systemic defense posture that results from a compromised immune system or a depressed host response, a weak immune system. Temporarily weakened by stress, smoking, poor oral hygiene, and or other environmental conditions. So what are acute lesions? Acute lesions are by definition are of sudden onset, limited duration, and with well-defined clinical features, unlike chronic lesions. By contrast, with chronic gingivitis, acute gingival lesions are usually easier to diagnose because they have somewhat robust clinical findings. So today we are discussing about necrotizing ulcerative gingivitis. Although there are a lot of acute conditions that affect gingivitis, but here we are focusing on three main topics, that is necrotizing ulcerative gingivitis, acute herpetic gingival stomatitis, and pericoronitis, that we'll be covering in the consecutive lectures. So what is necrotizing ulcerative gingivitis? It's a microbial disease of the gingiva in context of an impaired host response. It is characterized by death and sloughing of the gingival tissue and presence with characteristic signs and symptoms, according to 10th edition Carranza. So the name suggests necrotizing means that it is characterized by death and sloughing, necrotizing condition. It's a microbial infection in context with an impaired host response. So we are focusing here on a host response that is impaired. So this is all about necrotizing ulcerative gingivitis. According to the World Workshop in Clinical Periodontics 1989, it is a rapidly destructive, non-communicable gingival infection of a complex etiology. The commonly used terms are trench mouth, Vincent's disease, acute necrotizing ulcerative gingivitis, although there are a lot of other terms suggested since history, like trench gum, Vincent's stomatitis, septic gingivitis, putrid sore mouth, and so on. The historical background of the nomenclature and of how the disease or the lesion has arisen. The first reference was given in 400 BC by Xenophon. In Greek, soldiers were affected with sore mouth and foul smelling breath. John Hunter in 1778 presented a description of the similar clinical findings, and it differentiated from scurvy and chronic periodontitis. In 19th century, it was found in some French army soldiers, so that explains why it is called as trench mouth. In 1886, Hirsch discussed some of the features associated with the disease, such as enlarged lymph nodes, fever, malaise, and increased salivation. Plot in 1894 and Vincent in 1896 described this disease and attributed to its origin to fusiform and spirochete bacteria. It was also known as Vincent infection in those times. That is in the first half of the 20th century. So this is about the history of ANAC. Classification. Classification can be divided into 5 types: acute, subacute, chronic, recurrent, necrotizing, ulcerative, periodontitis. Acute, we are going to learn about the same in the later slides. Subacute is a form where there is diminution in the severity without treatment, and it has milder clinical symptoms. So it is known as subacute necrotizing ulcerative gingivitis. Chronic, although when we are talking about necrotizing ulcerative gingivitis, we are talking about an acute condition. So why it is called as chronic? So the cases that were inadequately treated or untreated, in those cases the destruction continues at a slower rate. So in those cases we term it as a chronic case of necrotizing ulcerative gingivitis. Recurrent, that is periods of remission and exacerbation, it recurs again, so it's a recurrent form. Then it's a recurrent form. Necrotizing ulcerative periodontitis, the tissue destruction involving the periodontal attachment apparatus. Although here is something to explain about is necrotizing ulcerative gingivitis never ever progresses to ulcerative periodontitis, because for periodontal pocket formation we need viable junctional epithelium to migrate apically to form a periodontal pocket so as to disturb the attachment there. But when there is necrotizing ulcerative gingivitis, the tissues are already necrosed, so there is no live tissue to go apically. So practically gingivitis never progresses to periodontitis in case of anug. It can only happen when there is existing pocket already there, or already periodontal destruction has happened, and over that an immune host response is diminished, and over that the required microorganisms were present to cause the anug lesion. In that case we call it as necrotizing ulcerative periodontitis. I hope this is clear now. Etiology. Etiology can be attributed to bacteria, host response, smoking, local predisposing factors, systemic predisposing factors, and psychosomatic factors. So starting with the role of bacteria, there were various scientists who discussed, who read about the occurrence of the disease since the 18th century, like Plot and Vincent and Rosebery and Losh and colleagues. They found in 18th century they found it as attributed to be fusiform bacillus and spirochetal microorganisms. In 1950, some scientists they described a fusospirochetic complex that was responsible for causing the disease, that consisted of T. microdentium, intermediate spirochetes, Vibrio fusiform bacilli, and filamentous microorganisms, in addition to several Borrelia species. Later, in 1982, they uh, described it as a predominant constant flora that consisted of Privotella intermedia species, in addition to the Fusobacterium spirochetal forms and Treponema and Selenomona species. So the specific cause of anuk has not been established yet, but the prevalent opinion is that it is produced by a complex of bacterial microorganisms, but it requires underlying tissue changes to facilitate the pathogenic activity of the bacteria. So the main microorganisms is a group of microorganisms, not a single organism. It will be fusiform bacilli either, or a spirochetal complex, or any of these microorganisms will be present in an anug. Now, role of host response is very, very important. Anug has not been produced experimentally in humans or by animals by mere inoculation of the microorganisms we discussed in the previous slide. In the animal model, they injected the animals with a glucocorticoid that caused the immune suppression in the individual, and which resulted in characteristic lesion of anug in infected patients. So anug is not found in well-nourished individuals with a fully functional immune system. What it implies is the presence of specific bacteria in the etiology of anug is insufficient to cause the disease unless until there is a diminished immune response in the individual. So this is about the host response. Role of smoking. In 1940, Pinborg and Stammers, they found a clear association between the smoker group and the prevalence of ANAG. So 98% of the patients with ANAG were smokers, and the frequency of this disease increases with increased exposure to tobacco smoking. So this is how the role of this is how smoking affects the condition. It causes vasoconstriction of the gingival blood vessels, and it might in this way they favor the colonization of the anaerobic bacterial flora. Local predisposing factors, pre-existing gingivitis might be there, injury, any kind of injury to the gingiva, any local factor that is capable of inducing chronic gingival inflammation can predispose to an individual to ANAC. Deep periodontal pockets and pericoronal flaps. We have already discussed about the topic of periodontal pocket with ANAC. So these areas, pockets and pericoronal flaps, pre-existing, offers a favorable environment for proliferation of the fusospiragetal complex because it provides an anaerobic environment for them to grow. Box in 1930 referred these zones as incubation zones. These areas of gingiva subjected to trauma from the opposing teeth in malocclusion, such as palatal surface in relation to maxillary incisors, in labial gingival surface in relation to mandibular incisors. These are the frequent sites of ANAG infection. So this is the local predisposing factor. Coming to the systemic predisposing factor, ANAG is often superimposed upon gingiva altered by systemic disease. So differentiation is needed to be made between the alteration in the gingiva those caused by the systemic disturbances and secondary sign and symptoms produced by superimposed ANAG. So what all systemic factors can predispose an individual to ANAG is nutritional deficiency. It accentuates the severity of the pathologic changes induced when the fusospiragetal bacteria complex is injected into the animals, and individuals who had vitamin C deficiency or intestinal fusospirogetosis had a relationship. Had a relation. So this explains why nutritional deficiency may be one of the factors that may predispose an individual to ANAG. Debilitating diseases. Many investigations have suggested that debilitating systemic disturbances may predispose gingiva to ANAG. For example, metallic intoxication, cachexia due to chronic diseases such as syphilis and cancer, severe gastrointestinal disorders such as ulcerative colitis, irritable bowel syndrome, or Crohn's disease, alcoholism, blood dyscrasias like leukemias and anemias, influenza and any acid-base disturbances, AIDS may predispose the development of the ANAG. So what we see in common in all these diseases is the immunosuppression. So this is how the role of debilitating disease in the ANAG. Psychosomatic factors. The psychological factor appear to be important in the etiology of ANAG. The disease most often occurs in association with the stress situations. The mechanism behind that is the psychological factors create or predispose the gingival damage, predisposed to gingival damage, and but this mechanism have not been completely established, but alteration in digital and gingival capillary responses suggestive of increased autonomic nervous activity have been demonstrated in patients who already had an ANAC. Cohen Cole in 1983, they have suggested the possible cause or the mechanism behind stress being the factor. So they proposed that the impact of any kind of negative life events, if the individual is undergoing any emotional stress or trauma, what it does, it may lead to activation of the hypothalamic pituitary adrenal axis, which in turn increases the urine and serum cortisol levels. And what cortisol does is it causes the depression of the lymphocyte function and polymorphoneutrophil function that may predispose the individual to ANAG. So this is about Psychosomatic factors. What is that? Does stress causes the adrenal, hypothalamic pituitary adrenal excess, which in turn increases the cortisol, which in turn causes depression of lymphocyte and PMN function. So it can be concluded that the opportunistic bacteria are the primary etiological agents of ANAC, that is the fusospiroketal complex, in patients who demonstrate immunosuppression, that is diminished host response, with stress, smoking, and pre-existing gingivitis common factors as common predisposing factors. Epidemiology and prevalence, it's about 54 to 58 people of patients are affected with the disease, mostly under the age of 10 years, and in other countries as well it has the same, although it does not have any common occurring with any particular season. There is no incidence. Communicability. The term communicable signifies a capacity of maintenance of an infection by natural modes of spread, such as direct contact through drinking water, food, and eating utensils, or via airborne route, or by means of an arthropod vector. In 1943, there was a scientist named King. He traumatized his own gingiva, and he introduced debris from an patient with a severe case of anak. But there was no response until he happened to fall ill shortly thereafter. Subsequent to his illness, he observed the characteristic lesion in the experimental area, thus showing that systemic debility is a prerequisite for contagion of the anag. Hamp et al. In 1961, he showed that the growth of fusospiroketal microorganisms require carefully controlled conditions and anaerobic environment, and they do not ordinarily survive on eating utensils. So in all likelihood, both predisposed immunocompromised host and presence of appropriate bacteria are necessary for the production of this disease. So in short, this is not communicable unless until there is immune response that is diminished and presence of appropriate bacteria. Both are required. Patient's history. What patients present with anag is characterized by sudden onset, sometimes following an episode of debilitating disease or acute respiratory tract infection, a recent change in living habits, protracted work without rest, psychological, emotional stress, and inadequate sleep, anxiety, depression, or any other emotional disturbance, poor nutrition and diet, tobacco and alcohol use. So clinical characteristics, we are going to study the oral signs and symptoms and extraoral symptoms. In oral signs, what we see particularly is, this is important, is punched out crater-like depression at the crest of interdental papilla. What we can see here in the image is these papillas punched out, crater-like depression of the interdental papilla at the crest of the interdental papilla, which may extend to the marginal gingiva and rarely to the attached gingiva and the oral mucosa, as we already discussed earlier, that if it is involving the attached gingiva, that condition might be case of the pre-existing periodontitis. This might be covered by a gray pseudomembranous slough demarcated from the remainder of the gingival mucosa by pronounced linear erythema. As we can see in this picture, this is the gray pseudomembranous slough that is having a linear gingival erythema at the borders, which is demarcated from adjacent normal mucosa, pink in color, and this is reddish in color. This is the erythema, and this is the gray pseudomembranous slough. If these lesions are denuded of the surface pseudomembrane, exposing the gingival margin, which is red, shiny, and often hemorrhagic, The patient may present with fetid odor, increased salivation. There is spontaneous gingival hemorrhage and pronounced gingival bleeding upon slightest stimulation. So, important point to remember here is punched out crater-like depression and gray pseudomembrane are the characteristic signs of ANAG with pronounced gingival bleeding, spontaneous hemorrhage. This we can appreciate in the picture, the punched out crater-like. The papilla is completely destroyed here, here, these areas you can see, and here we can appreciate the gray pseudomembranous slough. In clinical characteristics, now the coming to the oral symptoms. Pain. This lesion is extremely painful. The lesion are extremely sensitive to touch. The patient complains of constant gnawing pain that is intensified by eating spicy or hot food and chewing. There is metallic foul taste and the patient is conscious of an excessive amount of pasty saliva. Teeth seem to be wedged apart and are characteristically described as feeling like wooden pegs. Even without active intervention, the acute symptoms will subside and the ulcers heal in 10 to 14 days. However, the normal gingiva form does not return to normal. Gingival margin becomes thickened by the fibrous repair tissue and the papilla retains the concave shape of the healed ulcer. This saucer-shaped deformity of the gingiva, that is, we called it as punched out crater-like depression of the interdental papilla, is so characteristic of ANAC that an episode of a previous infection can be diagnosed years later. So what we see in oral symptoms is main is pain, extremely painful, sensitive to touch, gnawing pain, pasty saliva, wooden pegs, ulcers that heals by itself in 10 to 14 days and but retains that deformity in the interdental papilla. Extraoral signs, systemic signs and symptoms. Local lymphadenopathy, elevation in the temperature are common features in mild and moderate stages of the disease. In severe cases, there may be marked systemic complications such as high fever, increased pulse rate, and leukocytosis. Loss of appetite and general lassitude seen more severely in case of children. Insomnia, constipation, gastrointestinal disorders, headache, mental depression sometimes accompanies these conditions. In very, very rare cases, the severe sequela of ANAC can be noma or gangrenous stomatitis, fusus spirochetal meningitis and peritonitis, pulmonary infection, toxemia, and fatal brain abscess. Elevated temperature. So there is something to be considered about temperature. It is the most confusing and controversial diagnostic criteria. Why? Wilson, he explained that the elevation of temperature to 103 degree Fahrenheit and there is general malaise in patients with ANAC. Stammers told that the highest temperature recorded in his study of over 100,000 cases was only 100.1 degree Fahrenheit, and that is in most severe cases. Even in the most severe case, the temperature was only 98.8 degree Fahrenheit. So the presence of significantly elevated temperature and general malaise should immediately suggest the presence of some disease other than ANAC. For example, AHG, acute herpetic gingival stomatitis, may occur simultaneously with ANAC, thus causing the increasing temperature. AHG has some of the similar features to ANAC, but when we are in case of individual ANAC, the temperature does not rises much. Clinical course and sequela. Pinborg and colleagues in 1966 have described the following stages in the progress of ANAC. Erosion of only the tip of the interdental papilla. The lesion extends to the marginal gingiva and causing further erosion of the papilla and potentially complete loss of the papilla, that is punched out papilla. Third is the attached gingiva will also be lost. Fourth, the bone will be exposed. In 1995, Horning and Cohen, they extended that staging of the disease as follows. You please correlate the stages given here with the matter written in yellow color. Stage 1 is necrosis of the interdental papilla, tip of the interdental papilla. That is complete case of Anag. Stage 2 is necrosis of the entire papilla. Here only the tip is involved, here the entire papilla is gone. Maybe either NUG or NUP, because attachment loss may occur. If there is attachment loss, then it is NUP, and if it is only confined to the gingiva, then it is NUG. Stage 3 and 4 is necrotizing ulcerative periodontitis. What it is, stage 3 is necrosis is extending to the gingival margin and extending to the attached gingiva in stage 3 and 4. Stage 5 is it extends in the buccal and labial mucosa. Necrosis is exposing the alveolar bone, that is stage 6, 5 and 6. Then it becomes necrotizing stomatitis. Stage 7 is necrosis is it perforates the skin of the cheek. Stage 7, that is noma, gangrenous noma or gangrenous stomatitis. List-Carton described 4 zones which blend with each other and may not be present in every case. So there can be these all zone might be present or either of the zone. So there are 4 zones: the bacterial zone, neutrophil-rich zone, necrotic zone, zone of spirochetal infiltration. Bacterial zone, in this is the most superficial, that consists of varied bacteria including few spirochete of small, medium and large types. Neutrophil rich zones contain numerous leukocytes, predominantly neutrophils with bacteria including many spirochetes of various types between the leukocytes. Necrotic zone, zone 3, consists of disintegrated tissue cells, fibrillar material, remnants of collagen fibers, and numerous spirochetes of medium and large types with few other organisms. Then is zone 4, that is zone of spirochetal infiltration, which consists of well preserved infiltrated tissue with medium and large spirochetal microorganisms. So this is about 4 zone listed by List-Carton: bacterial zone, neutrophil rich zone, necrotic zone, and zone of spirochetal infiltration. Anag and chronic destructive periodontal disease. Anag may occur in a mouth that is devoid of pre-existing gingival disease, or it may superimposed upon underlying chronic gingivitis or underlying chronic periodontitis or periodontal pockets. It does not usually lead to periodontal pocket formation. I have already explained this why. It causes rapid destruction of the marginal gingiva in contrast with the chronic inflammatory and proliferative changes that occur in pocket formation. The impression that anug leads to pocket formation may have been based upon the cases in which anug occurred in patients with pre-existing chronic periodontal disease. Okay, so this thing is clear, I think now. Microscopic appearance, we discuss the microscopic appearance. Will be discussing the epithelium and the underlying connective tissue. In the epithelium, what we had seen was necrosis. The surface epithelium is destroyed and it is replaced by a meshwork of fibrine, necrotic epithelial cells, polymorphonuclear neutrophils, because phagocytosis is happening there, and various types of microorganisms. This zone, which appears clinically as gray pseudomembranous slough. At the immediate border of the pseudomembrane, when the pseudomembrane is removed, we find a hemorrhagic area. So the epithelium is edematous. Individual cells, they exhibit various degrees of hydrophic degeneration. Connective tissue is markedly hyperemic and with numerous engorged capillaries, vessels, and dense infiltration of polymorphoneutrophils. Numerous plasma cells may also be present in the periphery of the infiltrate. The epithelium and connective tissue alterations decreases as the distance from the necrotic gingival margin increases, blending gradually with the uninvolved gingiva. So this is about the epithelium and the connective tissue microscopic features. Diagnosis. It is based on the, most commonly we base it on the clinical findings, what we see clinically as punched out crater like depression in the interdental papilla and gray pseudomembranous slough. The clinical finding that the patient gives is of gingival pain, ulceration and bleeding. The bacterial, because the bacterial smear is not necessary for diagnosis. Bacterial studies are useful in differential diagnosis of an and specific infections of the oral cavity such as diphtheria, thrush, actinomycosis, and streptococcal stomatitis. Microscopic examination of a biopsy specimen is also not specific in this case. It does not differentiate enough from any other acute necrotizing conditions of non-specific origin, such as those that are produced by trauma or escharotic drugs. So the base behind the diagnosis is the clinical finding and the history that the patient gives to you. Differential diagnosis. Differentiation between necrotizing ulcerative gingivitis and primary herpetic stomatitis. So we are going to learn anyway about herpetic gingival stomatitis in the next lecture, so I am leaving this here. There are certain other differential diagnosis for a NUG, that is streptococcal gingival stomatitis. You can all find this in the text. Gonococcal gingival stomatitis, diphtheria, secondary stage of syphilis, agranulocytosis, leukemia, and so on. So moving to the treatment part, the main objective of the treatment of a NUG is alleviation of the acute inflammation present and the pain symptoms and palliative treatment. Plus, the treatment of chronic disease, if any, either underlying the acute involvement or elsewhere in the oral cavity, elevation of genetic toxic symptoms such as fever and malaise, correction of local and systemic predisposing factors, and obviously elevation of pain. Treatment can be divided into two phases: acute phase treatment and maintenance phase treatment. Acute phase treatment is divided into 3 visits: first visit, second visit, and third visit. In the first visit, what we do is we take all the patient's history, complete medical, dental, family history, complete examination, oral and general. We evaluate the presence of pockets or any local factors present. Treatment is confined acutely involved areas, which we isolate with cotton pallets. We desiccate the area, we put local anesthesia as it is extremely painful, and the area is then gently swabbed with cotton pallet to remove the pseudomembranous slough and non-attached surface debris. We clean it with warm water or saline or betadine. Ultrasonic scalers are very useful as they elicit little pain, and water jet aids. Subgingival scaling is extremely contraindicated due to possibility of infection spreading to the deeper tissues, and plus there is a lot of bleeding and it is a painful lesion. So we apply 3% of hydrogen peroxide with equal quantities of water, which helps in with removing the pseudomembranous slough or the necrotic tissue. Patients with ANAG and local lymphadenopathy and other systemic complications, we prescribe antibiotic regimen for them, penicillin or erythromycin, and or metronidazole or onidazole. So the surgical procedure usually would be avoided until 4 weeks after the acute symptoms, signs of ANAG have subsided. If emergency surgery is required in the presence of acute systemic antibiotics are indicated to prevent worsening of the spread of the acute infection. Instructions with the patient, we tell the patient of the existing condition, extent and total treatment. The condition requires and we want the treatment is not complete when the pain stops. Advice: mouth rinses with 3% of, this is the first appointment we are talking about, 3% of hydrogen peroxide with equal quantity of water every 2 hours, twice daily. Rinse of chlorhexidine and gluconate along with that is of 0.2% concentration. Normally to avoid tobacco, alcohol, physical exertion, confined toothbrushing to removal of surface debris, and with the bland dentifrice, and report back in 1 to 2 days time. That will come to the second appointment, that will be after 1 to 2 days of the first appointment. We check for the patient condition for improvements, and scaling is performed if sensitivity permits. The gingival margins are still erythematous but without superficial pseudomembrane necrotic tissue. We repeat the instructions given in the first visit. Then come to this third visit, that will be after 1 to 2 days after second visit. At this time, we discontinue the H2O2 hydrogen peroxide rinse, and we ask the patient to continue with the chlorhexidine rinse. The same things, patient motivations and the same instructions will be given, and some amount of erythema might be present in the third appointment as well. Now coming to the maintenance phase. In this maintenance phase, all the acute symptoms are gone, and we go for the complete scaling and complete root planing in these cases. Root planing when periodontitis is involved. Correction of the restoration margins and polishing of the restorations, if any, motivate the patient for complete treatment of the underlying and the residual defect. We schedule the patient for treatment of chronic gingivitis, periodontal pockets and pericoronal flap, if any, as well as elimination of all forms of the local irritations. Additional treatment consideration might be required. In some of the cases will be recontouring of the gingiva as adjunctive treatment procedure, supportive systemic treatment in form of copious fluid consumption, that is always helpful, nutritional supplement in form of vitamin D and vitamin B and vitamin C complexes. Patient should be placed on natural diet as soon as possible. So this completes the topic of acute necrotizing ulcerative gingivitis. So the topic will be continued in the next lecture, as acute herpetic gingivitis stomatitis is left and pericoronitis. Thank you.